going into other complex cases. So converting ankle fusion to replacement. So we've heard about ankle fusions, long considered the gold standard, but historically very high risk. So we've heard high risk of non-union, especially historically, malunion, stiffness, decreased range of motion, periarticular arthritis, and also just pain of unknown origin. Sometimes a perfectly well-appearing fusion, very painful. And patient satisfaction will also decrease as the interval from the fusion increases. Mirrored this study showed 80% of patients will have difficulty with uneven ground, 75% difficulty with stairs, 65% will ache after prolonged standing, walking, or working, 20% difficulty even getting out of a bath. So clearly can have many limitations, even the so-called successful ankle fusion. So, but what are our options for the painful ankle fusion? So you could certainly consider revision, but non-union rates are higher for that as well, up to 50%. You can consider extending it and doing a subtalar, pantalar, but those revision rates are even higher, up to 50%, and certainly creates a very stiff foot, problems with uneven ground. You can consider amputation, which can be a successful surgery, but typically not well accepted by patients, and also much increased energy expenditure with gait. Or you can consider conversion to a total ankle. So that's what we're going to talk about here. So the goals of a total ankle after a failed fusion are the same as if we do it primarily. So pain relief, try and get functional range of motion, improve your gait and function, decrease the stresses on surrounding joints. The challenges of the takedown are challenges we see really with most revision surgeries. So certainly the skin, previous incisions, scarring. Sometimes it's difficult to locate the original center of rotation of the tibio-talar joint. How much bone do you have to resect for the implants, and where is that bone coming from? What is the quality of the bone stock and the strength of that bone after it's been fused? Has this canal that's evident there and been stress shielded? You have a relative narrowing of the mortise after a fusion from the compression. What's the status of the fibula? And what's the competence of the ligament? So sometimes you may have a fused ankle that once you free everything up, it actually might surprisingly be unstable as well. So also these are typically very long surgeries. You have to be mindful of your tourniquet. Certainly the longer they are, the increased risk of infection. And these wound closures can also be very complex with multiple incisions and long tourniquet times. So really just few studies in the literature. Some of them more recently, fortunately, the earliest one was Greisberg, looked at 19 ankles. They had done freehand cuts. They used an older prosthesis, showed some improved functional scores, and patients overall were satisfied. But at the time of the takedown, they had over half of them patients had malleolar fractures, and a quarter of them had actually had the lateral malleolus resected. And so this led to a valgus tilting and translation, and again, with an implant that had difficulty maintaining the mechanical axis to begin with. So really it was about 50-50 how these patients did. And so they determined that patients need to have a clear source of pain. These patients do better if they have a clear source of pain, typically increased pain with activity. And they recommended that any patient that had the lateral malleolus resected would have a complicated course. So didn't recommend this procedure for those patients. Pinterman then did a study with a mobile bearing prosthesis and showed similar range of motion afterwards, increased functional scores. Again, high patient satisfaction that they reported. A lot of simultaneous surgeries performed, fairly high number of intraoperative complications. And again, these patients, again, had a defined reason for the takedown: painful malunion or stiff, painful arthritis of adjacent joints. And they showed some improved results compared to Greisberg, and they felt that takedown and conversion is a viable option. They came up with a series of contraindications for doing a takedown that are listed here, and relative contraindications, including the absence of the fibula, significant malalignment, instability, and demand for high-impact activities. But again, they felt that a defined reason for pain was really the main indication. So more recently, Pellegrini looked at some 23 patients that had a procedure again. Again, a lot of these had concomitant procedures done, but showed improved pain, improved function, about the same range of motion, that 20-25 degree range, high implant survival. But again, the patients that had a fibulectomy both failed. They also showed very high evidence of talar subsidence, and a bunch of these required revision for this. Again, 43% minor complications that did not need surgery. So they concluded that, again, this is a complex surgery with complications. They recommended prophylactic malleolar fixation for all these cases because their intraoperative fracture rate was almost 10%. And they also did not recommend to do this in patients that had a distal fibulectomy. Huntington also did a study, looked at just a short, small study, 5 patients. They didn't have any loosening or subsidence, and again, had most of the patients would do it again. Sugarworth had the largest study, and they showed results that are a little bit better than most of the other studies. Implant retention, 87%. Range of motion, again, around 20 degrees, and a longer interval to take down after the fusion did not correlate with poor outcomes. And then Dean also looked at 50 patients, improved pain and function. So we've seen that the studies, as we've gotten more experience with this procedure, appropriate indications, and better technology in terms of implants and technology to assist us, the results have improved from being a 50-50 procedure to maybe something a little better in the right patients. So what are really the indications you should use to consider doing a takedown? So certainly the most important thing is should be pain, specific pain, aggravated by physical activity. So this can be found in a variety of these situations you can see listed here. Certainly contraindications, some of the obvious ones, active infection, neurovascular patients. Also the skin you have to be very careful for. Bone stock is very important, and also probably severe deformity and or instability. I think you have to be careful with patients that don't have a clear source of pain. So this is important in your preoperative evaluation, and you can also use selective injections to determine where the pain is really coming from. And certainly if they have absence of a distal fibula, that's been shown in most studies to be a contraindication during this procedure. So in terms of when you're planning to do this in your patients, you want to obtain all the prior operative reports, know exactly what was done and when, get a sense of what the length of time was since the original procedure, and really find out where the pain is coming from. A lot of times you have to worry about wounds in particular, so you want to have a full team approach to be prepared for anything. You always want to assess the skin, the soft tissues, mark out the prior incisions, check the alignment and stability of both seated, standing positions, neurovascular status. Do all your radiographs, including dedicated foot films. You can do the 3-joint standing to see about extra-articular deformity, and obviously your most advanced studies like CT scan, which can help assess the union of that fusion, the alignment. Also gives you an idea of the bone quality, the bone stock, bone defects, which helps you decide if this is an appropriate patient for the procedure, but also helps you plan out what other concomitant procedures you may need to do, and if you need to stage this procedure with other procedures. So this was my first one way back when, who had this painful fusion, aggravated activity. You can see that she had something going on with the fibula from prior. It's very thinned out. Would you plan out the incision, typically anterior approach, deep retractors, and depending on the implant system you use, you line it up. Again, you're going to preoperatively know if you have bone cysts that you're going to template. You prophylactically thin and screw your malleoli. And then while you're intraoperatively, though, you can assess the bone quality and the strength. Sometimes it's tough to find out where the old joint line is. Sometimes you're lucky, you can see where the old fascial scar is, and that can give you some reference. In general, you want to try and protect that talar bone, so maybe hedge a little bit higher, but you don't want to go too high, because when you get 5 to 10 millimeters above the tibial joint line, the bone quality starts going downhill as well. So you have to see what the size of the implants are of the system you're using. I think these are good cases to do the posterior medial release that we mentioned before. So you make a small incision posterior medially and use blunt dissection to get and expose the posterior aspect of the tibia. I take a radiograph to confirm that I'm all the way lateral, and then I'm back behind the joint. So you want to get an adequate capsular release, which provides for better range of motion eventually, but also protects your soft tissue structures. Dr. Sanders patented this new spoon thing there, which fits in nicely there. It comes in 2 sizes as well. And then you can make your cuts. So this case was back before any pre-templating system. So these are free-handed cuts. You can do a monoblock, and typically I don't couple my cuts. You want to make sure that the cuts are perpendicular to the long axis of the tibia. And then depending on the deformity, if there's a malunion for the fusion, you want to be perpendicular to talus, and you then correct the malunion at the time of the surgery. Fluoroscopy will conform the cuts, and you can use a reciprocating saw to finish it, median and lateral, to make sure you get your flush cuts. And then at this point, you can start debriding the posterior capsule from anterior to posterior, and remove the posterior tibial osteophytes. You can use the cob again to come up and release as well some of the posterior capsule. And having done that posterior medial release, you can see where your malleable is going to be. So here you can see where the malleable is posteriorly there, and that will protect your structures at risk. So that will protect them during the bony cuts. It also allows you to debride that adherent posterior capsule sharply from front to back. Once you've done that, you're planning out your gutter anatomy. And so you're going to make your cuts, your super infra cuts, but it's very important once you've removed this that you have to then address your gutters and you don't try and move the foot because you will fracture your malleoli. So even if they're pinned, I mean, you will still break them. So you have to remember that you still have to wait to free up the motion before you start trying to move the foot. And once you've done that, then you can start going and proceeding with a regular total ankle. So doing your inserts and trials and everything else. And then once everything's freed up, then you assess the range of motion. And you look for the appropriate stability, the appropriate size spacer, and then you can consider adjunctive procedures as well to improve your motion or to stabilize the ankle. You want to balance it. You can do some procedures simultaneously to get the hind foot alignment correct as well. This patient also had subtalar joint arthritis, so did this at the same time. And then again, had to address this fibular anomaly, which really wasn't an obvious non-union, but was very thin, and I wasn't comfortable leaving that as my buttress. There are some studies in literature. Hinterman talks about when he has a fibular insufficiency, and they talk about lengthening and plating, and I would recommend doing this in a staged fashion if you were to consider this. Schubert talked about restoring the buttress either with a large structural crust bone graft or a malleolar relocation with grafting. Again, these are things I think if you were going to consider this, I would do this in a staged fashion. In this situation, I got lucky, and then basically it was very thin, and I was able to span it with a plate. It was too thin for even for a 6mm screw, so I ended up putting a few wires and got lucky, and it healed well. Nowadays, we have better technology. So we have patient-specific instrumentation, which we've seen for primary total ankles and knees and hips, for that matter, are very helpful, excellent surgical planning tools to try and help us make better neutral alignment, make these procedures much more accurate, but also reproducible, help with implant sizing, efficiency, decrease blood loss, cost effectiveness. And I think that this technology is extremely helpful for these types of procedures to help optimize our intraoperative performance. So it helps us identify the joint line, helps us identify the gutters and plan out where we're going to put the gutters, helps us restore the coronal sagittal, but also especially the axial alignment, helps us with proper implant sizing and placement, which can save a lot of time, helps us assess the quality of the bone stock, evidence of cysts, osseous defects, periarticular deformity, which allows us to also plan the concomitant procedures. So, and that can also help you decide if you can do it in 1-stage or 2-stage. So this was a 52-year-old woman. She had an MVA 2000, crush injury in the ankle, injury to the knee, and over the years had increasing pain, especially with activity, swelling a lot of times, difficult to walk pain in both ankle and the knee, but ankle more than the knee. So these were x-rays, and again, she had pain at the knee, some early arthritic changes, and you can see the ankle fusion. It was a painful, well-healed fusion, but a painful fusion, and she's developing some periarticular changes. So the plan with her is to stage this. Is to stage the hardware removal, and not make an anterior incision in the ankle. I didn't want to compromise that soft tissue envelope, so left the fusion plating, took the screws around it, took out the nail, and then I can treat the knee separately. Then I get a new scan, a CT scan with the plate in place, and this can help prepare with the PSI for the blocks to then plan for your definitive case. So you get your PSI, as we saw earlier, with your plans for the cutting blocks, and you can see the hardware's in there. And so you have guides that are templated to fit over the existing hardware. It helps you see what that's going to look like. And then you can go back and really do your plan. So you mark out your incisions. You have your blocks that are going to go over the hardware. So you first put the blocks over with the hardware inside, and then you pin it. So you have your pin sets in place. You take the blocks off, then you can take out the remaining hardware. Then you put the blocks back on, as you can see in the bottom film, and then you can start doing your cuts and moving your bone. Again, I do this posterior medial accessory incision to remove the adhesions and protect your neurovascular structures. You do parallel cuts and mobilize your gutters, do your reaming, and do your implant placements. You do an extensive gutter decompression with these, as you can see there in the bottom right. You want to make sure that you got a lot of room, a lot of motion, and then you do what you have to do to improve the range of motion. Typically, these patients are stiff. So I agree with what Dave said before. I don't do TLs very routinely anymore, more of a gastrectomy recession. Their strength is much better afterwards. So you can see here I always tested before and after. So you can see after she got great range of motion here. And these are finals. So overall, this did well. So multi-layered wound closure. I used hydrolyzed collagen as well in the wounds to try and get them heal. And I immobilized them pretty similar to a total ankle replacement primarily. I always let patients know that the recovery, though, can take longer than a primary total ankle. I remind them that these procedures are really a salvage option for their ankle. And so you want to make sure the patients have appropriate expectations for this procedure. And then they're going to be happy afterwards. So again, these are complicated procedures. There's no such thing as a quote unquote simple takedown. These are really for more experienced surgeons trained in total ankles. It's important to plan and prepare your newly created joint line. You have to anticipate additional procedures, be prepared for that. And you want to try and avoid the most common complications. So the most common complications with this procedure are malleolar fractures. So I recommend prophylactically fixating all your malleoli. You want to make sure you don't cut too proximal in the tibia. They usually tend to downsize in the talus. You downsize means you cut less bone, so you preserve some of the talus bone stock. And make sure you don't move it before you've made all your cuts, including your gutters, because you will fracture. I think it's also important to protect your neurovascular structures, which will be adherent back there. So I think making just that small accessory posterior medial incision helps a lot. I think, again, our indications have improved, our experience has improved, but our technology has improved. So we have much better implants right now to deal with this kind of a revision setting. And I think the PSI is extremely helpful to optimize our intraoperative performance. It makes us more accurate, more reproducible. It also decreases our OR time and our blood loss. It can be a reliable option. When I first started doing these 15 years ago, I told patients 50-50. I think you have to remember this is still a salvage procedure, but our results are doing better. And patients they should expect residual pain, but the pain should be less than what they had preoperatively. But in the right patients, they can do well. We still don't have any long-term studies. So all those studies I showed you are really short and midterm, but we'll see long-term. Hopefully these patients do well.